grounded in research, individually focused, and back at last. Welcome to the Thriving with Stripes podcast.
All right, welcome back to Thriving with Stripes. Today's episode is number 8, talking navigating patient appointments. Kind of a deep topic, probably some equal input from you and I.
Sure.
From a bunch of different aspects, right? From provider, spouse, partner,
Patient.
parent.
Oh my gosh, parent. Yeah.
Non-vocal partner, like when I just watched you suffer and I didn't have the tools to like combat and help.
Sure, all of the aspects.
Okay, so big topic. It's probably worth it to frame this thing into a couple categories first of like where we want to start. I mean, we have things like the rights that a patient has during an appointment, right? Like steadfast nationwide by the state. We also have, things that you can do and kind of push some of the chips onto your side as a patient going into a higher stakes appointment. Is there any place that you'd like to start?
I think we should start with just a little bit of realism around appointments, because I know that people with connective tissue disorders have multi-system involvement, especially the more complicated or inflamed somebody gets, right? So we do have to be realistic from the patient side as well, and from the doctor side too, right? From the provider side of how much can we help during one appointment or how much can we get done during one appointment. And one of the things I do when I meet somebody for the first time, and they fill out this extensive form and there's so much that I want to talk about with them, I still always check in, even if they write, I'm coming in for MALS, median arcuate ligament syndrome, or I'm coming in for upper cervical instability or tethered cord. I still have a lot of questions that I want to ask. How'd you get there? How did we end up in this place? But what's most important to me as a provider is what they feel like they need out of the first appointment or two, especially with so many things going on. So that's typically how I start an appointment is I'll ask somebody, hey, with everything that's going on and all the hats that I wear, have you even thought about what might be helpful in this appointment? That if you left here, you had some questions answered or had a path you felt a little bit better about. But what is the one thing that we need to get to at this appointment? Now, it's not necessarily just one thing, but in the first appointment, if you're meeting somebody, there's usually not enough time to get through more than one thing, to be completely honest, because we might have a printed list of your history, but I'll tell you, most of what I learn is the translation of that, of tell me more about your timeline. I saw that you had this injury. Tell me more about it. It seems to coincide with when you weren't feeling well.
I'll kind of add, as much as you're appropriately teasing out and connecting dots, a lot of it goes both ways. You can see the light bulb go off from a patient standpoint. And it's almost like as soon as I see that, there's some vigor that comes with that curiosity of, wow, I've never even had anybody remotely answer, let alone entertain that question.
Yeah.
And I'll kind of shift my chips and focus just there because like, hey, that seems like a pretty high stakes, valuable target for you to go after.
Yeah. So I know that I've heard this before is from other providers recommending, hey, pick 3 main things that you want to start getting things done with. And I'm like, gosh, you have time to figure out 3 things, where they came from, which means that you know how to address the symptoms that manifest. Like that's a lot to figure out 3 things in one appointment. And also, again, if we're like, okay, I think you might have tethered cord, in my treatment practice anyway, it's actually more important to figure out how you ended up with tethered cord. That's a neuroimmune response. We've had another podcast about it.
Kind of
or like mast cells, or
the thought of like the Rubik's Cube is like twisted and jumbled up. Okay, this is where you're at now. How did we get, what were the turns that caused you to get to that?
We kind of have to backtrack a little bit and figure out, and the same like with mast cell activation syndrome, you can have a predisposition to this, including connective tissue pathologies and also other genetics, but it doesn't inherently mean that you're going to constantly have mast cell issues. It means that there might be an underlying thing that's driving it. And that's what we need to know. And that's why it's not as simple a lot of times as like, let's just give you some medication. But so Yes, I think, just the realism of understanding that this is much more complicated than just throwing things at people because you're going to list 3 things that I want you to get done for me. Just the way that I work, it takes a while to figure out one thing. And even if we put you on some mast cell stabilizers, that's really still just what I call like a mop strategy. We're just mopping up the spill. We're not turning off the faucet that's leaking. So that's the next conversation. But really understanding, again, the realistic nature of we might not be able to answer everybody's questions in one session. And it's not appropriate to do so, right? Because we actually might not have all the answers. We need to learn more about the individual. So the realism of, depending on how much time you have with a provider and the provider with the patient from the other side of things, where can you do the most good in the first few appointments to focus on for that individual? And it might vary.
So that's from your side, and then I'll kind of throw in, like from my side, I'm framing this like a teacher lesson where I'm imagining my admin walking into the classroom and making sure I have a content learning objective on the board and making sure every single student can tell them what we're learning about so it's framed and relevant. Same kind of deal. What I'm trying to do is set up like, what's our framework? This is where we're going to work in. Yeah, what's burning, hot topic on your brain? Is there anywhere we need to start? What I have found is that, and this goes onto kind of the patient side of things, if you're overwhelmed, like I kind of try and pull that out right away. So I kind of give people 2 routes, and this is a good way to consider, I think, from a patient side of things, from at least my idea. You can give me some feedback on it, but what would you like to do? Would you like to lead the appointment and let the patient kind of hit questions and start to connect dots? Or would you like from the thorough intake and from our, I'll text sometimes or, have a little bit of early communication with some of our patients. From what I know already, would you like the 30,000-foot view, knowing that both of them are going to leave you, even if you have good expectations and low, like, we're not going to fix everything, you're probably going to be overwhelmed.
Oh, yes, because this is an overwhelming topic.
And
if you don't know that already,
I'm a lot, just to let you know.
Right, because there's a lot, and like we kind of have our fingers in a lot of different things and understand the connections. No, but I think it's just a different approach. I think we say the same thing, but in a different way, because a lot of times when I say, what would be helpful for you today? I have people that pull out their notebook and they're like, well, can I just rapid fire questions at you? And I'm like, absolutely. And that's part of what I think that we need to talk about today too, is autonomy and control of the patient having, a part of this relationship in their healthcare. That's really important. But that's why, like, I usually let them lead. I have some people, rarely, but they do come in, they're like, I don't even know where to start. And I'm like, okay, I got this. One of the first things is redefining what connective tissue is for people. And I'm like, let's pause for a second if we don't know this. And a lot of times that's where like all of the questions end up. And I'm like, hold on, let's actually pause, and then we'll come back to each individual question. But I want you to understand the condition that you're dealing with first. So similar, having them lead or you leading, I think I just start with a question that kind of drags that out at some point. Yeah.
So from a patient side, so it's provider like focused, right? From a patient side of things, you're listening to this podcast and you have a higher stakes appointment coming up with a neuro team or like a unit that specifically works on POTS. And, that's what you've been told you have. And, this clinic specializes in it and you're kind of going into it. Obviously, like notebooks and questions, I would advocate for patients' abilities to be able to speak and say, these are kind of the things, either if there's a portal to be able to present beforehand that I would like to do. I think to our system where I always appreciate the little notes people write in of, hey, neuro stuff, tons of neural inflammation, need some help, for like a patient coming in with you so that you have a little bit of framework. At being a patient and a provider, like anything that you've used that you found successful in going to visits.
Yeah, I do like the idea.
I also think if you've had any successful provider visits.
That's why I have some suggestions. Thank you for asking. So, because I am a patient myself first, right? Like I consider myself a patient first and a provider second. And obviously when I'm in the clinic differently, but I've been through all these experiences myself, and I try to take them all as calmly as I can. But even being a provider, I get gaslit constantly. And you would think the further in my career I get, it would lessen. It really hasn't. So I would say two of the top things that I think are helpful, depending on the needs of the patient, are writing things down before you go in and having an agenda and sticking to it, getting out of your own way. And I do want to talk about that a little bit more. And then having a somebody come with you. Um, Interestingly, appointments sometimes go better when you have another body in the room. So those are the two recommendations that I think could be very helpful. In regards to writing things down, I bring that up because I can't tell you how many times I went into an appointment, and the second I realized that this was going to be difficult, I was going to have to explain things, I was going to have to defend myself, I shut down. And I realized, you know what? I'm actually fine. And all of the stuff I came to talk about, I'm like, I don't want to talk about this with you. So I think writing it down and having an agenda and saying no, and like it's on the gosh darn paper in front of you. This is what we are going to talk about. I need to talk about this with somebody. And this is where I want to talk about language today. Being on the provider side, like I understand even the best providers, we can catch on not a great day. I try not to ever be that provider, but I'm sure that, I just haven't meshed well with some people out there. But figuring out how to interact with providers so that if we catch them on a bad day, that we use the language that appeals to them, such as, well, I just wanted to rule this out. That works so much better, really it does, than saying, well, I heard about tethered cord and I think I might have it. But
Or coming in cold with like the tethered cord research and just presenting it, kind of assuming that even if they actually haven't, but assuming that the provider hasn't interacted with it at all.
Yeah. And that's what, like, from the neurally diverse side of things, some of us are always like, why wouldn't they want to know? Like, I want to explain how they're wrong, because I get into that mode as well. Like, no, I just want to educate them. And not all providers like to be educated. So that's where, if we use certain language, and this is really important, and I tell my patients, I coach them on this all the time, use language that will get you the same results, but it's a different interaction. So a lot of times it is on the negative side of things is, I heard about this condition. I have a lot of overlap. I'd like to rule it out. And what the doctor hears usually is, they don't necessarily think that they have it. They just want to make sure that they don't have it. Not that, they want to prove that they have it.
To help them navigate those waters too.
Right. So I know it's a pain in the tuchus, but watching language like that and figuring out how to frame it so that you're trying to tell the doctor, it's like, yeah, I think I actually might have this, but also it'd be cool if I didn't, but like, let's do some investigation on this. And I probably have to go to another provider besides you if this is how we're going to handle things.
I mean, that whole ego thing is a very delicate space. The people out there that have grown up around parents or older siblings or people that you just know, my end goal is this. I know that I can't go straight there. I'm going to go around and set up and plant a seed and to get to this eventually. But navigating that with certainly certain providers, I mean, tangential here, but sprinting, I'm a fan of track and field. Ego in the world of sprinting is huge. And I think there's some small place of it where it's justified that you have to truly believe that you're there and you belong there, and it gives you that 0.1%. But in the space of health where it's not on a world stage and being judged, that's where I plead for providers to like ramp it down and be wrong, like just lower it a little bit.
Yeah, just
not to be as delicate and fragile and not vulnerable around your patients.
Right. Be more receiving. And that's what I see. I feel like there's a lot of people that just put up walls where they've just decided that that condition doesn't exist. There's no way that you have it. So this conversation is over. And what I have learned through my patients is there is literally no black and white in any of medicine. And for all the times I say, I have only seen people appear this way with this condition, I will have one person that's completely different. Or if we think that this one treatment works for everybody, I will meet the one person that it doesn't, and it should have, but it doesn't. And that's the cool and awful thing about science is that, and medicine is science. And this is where, like, we have to be receiving to hearing, no, that's not me. No, that doesn't work for me. And can you be open to considering that this might be a possibility?
Yeah,
And
because the best researchers in the world aren't the ones that are always spot on with their hypothesis. They're the ones that can completely have the results go the opposite direction and then take that and pivot and work into the next space.
and still report their findings.
Right.
Yeah, I know. And being a little bit more in the research world and talking with some people, I have talked to some people that openly admit that depending on how our research goes will dictate if we publish it. Meaning they're only going to publish it if it gives them the answer they would like to see.
It kind of fits the narrative that maybe they practice under, the paradigm that they treat.
And that's where research is still biased. And also, like, for whatever you read, you're going to hear research that supports and then research that goes against. It's just how it works. So that's where, like, understanding the really embedded science between what we're talking about is the helpful part. So yes, being open as a provider can be very helpful.
I think another thing that's helpful from a patient standpoint is to know almost a little bit, of your personality tendency. That's helpful, especially if you are a little neurodivergent or it's sometimes hard to, for everybody, you walk into a cold appointment with a provider you have no relationship with and oftentimes are meeting for the first time in a 10-minute window in a room, where it's hard to read the room. You're like, I just walked into this tiny little room. I don't have any sense of it. One thing I like to think about, and this is kind of a little bit of a coaching hat piece of what I leverage, is people's personality tendencies. Are they kind of rebellish? Are they a questioner? Are they an obliger or like an upholder? Anywhere in this realm, if you know where you naturally are, that can help you steer and dictate how you run your appointment. If you're naturally a rebel and somebody's going to come at you, you don't know how anybody's going to respond, and you love to do hot yoga, and for whatever reason, it's stabilizing for your autonomic nervous system, even though everybody and you're doing salts afterwards and you're prepping beforehand, and it's like the last thing you're holding on to. And everybody in the POTS clinic is like, you got to stop doing that. If you're a rebel, like you mentioned, you're going to shut off after,
absolutely.
You're going to like appropriate fingers, and I think knowing that and being able to call yourself out of like, hey, people might come at me, rehearsing it, planning, like, what am I going to do if they tell me not to do this? Okay, I'm going to ask them like maybe for some input or why or what else I can do.
Yeah, and that's where the autonomy in the relationship, so the patient's autonomy and being able to be a strong part of the relationship, is over and over throughout the research has just shown that it improves outcomes. And this is where there has to be a collaboration between patient and provider. Granted, in some cases, it is helpful for the provider to say, I got you, let me guide you. But then over time, there has to be autonomy because the healing process comes from the patient themselves. All of the other providers are just guides, even hands-on providers. It's the patient that's doing the work. It's the patient that's getting through the next steps. So the patient has to have a say in what they are doing. And this is one big thing that comes up with our allied health professionals group is people all the time ask, my patient doesn't do A, B, C, or D. How do I get them to do A, B, C, or D? And when my patients come in and say, I'm not doing A, B, C, or D, I'm like, that's great. What would you do? Where are we right now? From the side of being in the position of, you're not going to get me off of the couch right now, I literally can't function. I understand that. So you're not gonna make me do something, especially because I have that rebel side to me where I don't like to be told what to do. Also, I can only work out if you tell me what to do. I have a very complex personality. I don't know if you knew that. Um, but it's this autonomy that we need from providers or from patients to be able to say, like, no, I can't do that. What else do you have for me? And we should be able to pull it out. We should not be forcing anybody to do something or to try to get them to do something that they're literally telling you, I don't have the capacity to do that. I've even worked with, especially like parents working with their kids. And I'm like, look, at this point, can you carry their supplements to them and have them take it? They're telling you, I can't take them. I can't remember to take them. And when I asked the kid, I'm like, if somebody brought them to you, would you take them? Yeah, absolutely. Like there's almost a relief to it. Look, we've got to find this middle ground. And that's where the patient has say in their treatment. But please, if they're telling you, I can't do that, if you want them to do that thing, you have to ask them, okay, how do we get there? And then you make a plan for that. But please don't figure out a way to just train them to do it, to switch the way that their system is working. I have not seen that work. And again, we're always wrong about everything in science, right? It will work with some people.
Sure. I mean, this concept of progressive overload just applied to all the things is,
Sure,
not really worth its weight, because it's not going to land. It's going to land for a good chunk of people. There's going to be research that it does. And I can tell you for most of by the time people get into our office, a lot of standard linear-ish progressive treatment paradigms don't work.
Yeah. Also, like, I don't know. I've worked with so many tired patients at this point. Why would you want to make them do anything? What, like,
Right?
why?
Just take a step over and be like, what can we do? Like,
yeah. Why does that come to mind first? Like, nope, this is what I need you to do. I don't need my patients to do anything. I want to know what they're capable of doing.
I think it's the nature a little bit of medicine. I mean, to answer your rhetorical question of, things are scripted, and things work for some people. And, to the providers out there that are maybe younger in practice or creating their own treatment paradigm, it's going to take the people in front of you to show you what works and what doesn't work. And eventually, if you do it long enough, you'll realize that nothing works for everybody. And it's literally up to, like you've said many times, your patient to reveal to you how to kind of guide them and steer them in what direction.
Right. It has to be a collaboration. And this is like, so that we also, I'm just going to tell a little story that's happened to me many, many, many times. But to call out a little bit on the patient side of things, but also we can't force you to do anything, is I've had a number of patients that come in and not like they're pointing fingers, but just like, I don't feel any better. I'm like, well, that's because we haven't done anything. Like, and I understand, but that's what I'm like, okay, how are we going to start doing things? But if we don't change things, if we don't start to work on them, things won't change. And sometimes people do just need, okay, I just need validation first. I need like my autonomic nervous system settled and I need to work on that. Cool. But also, I've been asking you to take those supplements for 3 months and you haven't started them. So I'm not surprised that you're not better yet. I also understand that you don't feel well. So that's why I was on the non-judgmental zone. But I want patients to understand that if we're not trying some of the things that are being recommended to us, then we can't expect change. It might happen, right? Again, there's always going to be an exception to the scientific rules, but we're not necessarily going to see the change. So yes, at some point we have to start to move forward, but I can't make that happen for people. Oh my gosh. And especially when there's external stressors that are beyond our control, like relationship status, work issues, divorce coming up,
housing
issues. Yeah. And so like, that's where I'm like, let's just hang on. Can you do any of these things? But I do want to say, so that the patients hear this too, please give it a chance. If you're like, I'm not any better. Okay, but we haven't gone very far and we have so much to work on, so much. But also the capacity for an individual to be able to work on things might be slower, and that's okay. That's where like some
just
people,
not even at the right time.
No, it might be the wrong timing.
This discussion with patients of, even you and I, where, we're starting to make some moves in the right direction, and then it's gone. And, they're off the grid, if you will. And 2 years later, they pop back on and, all right, here it is, like my housing's better now, or I
Mhm.
went through that divorce. Like I'm stable on my income now and I'm ready to start.
Yeah,
And you're like,
awesome.
cool.
But as a provider, we can't make that happen any faster. Like we can offer some supports and some passive things and things to try, but it's still, that's what, like, this is so difficult because it's all on the patient to implement these things and to find the energy to keep it up and to try. This is really difficult from the patient side of things. That's why, like, I'm not judging or calling people out because I've been there too. And I tell people, if you're going to protest, celebrate and protest. Like, that's also the autonomy part. Like, I can't do this right now, so I will not do this right now. But if it also comes to that, I want you to give yourself a deadline then. Like, how long are we going to not do things for? How long are you going to enjoy your break of not doing things? And then what can we start at the end of that timeline? How can we just start to shift it towards the consistent working on these things? And some people can't do it, and that's fine, but we can't force timelines.
And it's tough because as a patient, you want to get better now.
Oh my gosh, yesterday. Like, when I was a kid, I'd like to feel better back then. Yeah, no, it's so incredibly slow.
How do you manage compartmentalizing like all that BS from kid to teen to college to young adult to, all the former moments of gaslighting when you go into somewhere new? Is it just like bottle it all up in a neat little package and get through this?
I think I did that
Is it
for a
kind of
while. Like, my personal experience was I did that for a while, and I was always really hard on myself, and I would always, it was always had to do with me. It was my fault. It was the way that I handled things. And then I would replay the circumstances over and over. I would just replay it like a broken record, and my anxiety would just eat me away. And through my healing process in the last like 8 years or so, I've actually done a lot of work on realizing that it's okay for bad things to have happened to me, but I don't need to hang on to them right now. However, there are some things that were so deep, like when I was writing Dare to Dazzle, and it was actually not even when I was writing it, but when I had to go back and reread it for the editing part. And I kept getting to the part where our little guy, I had to hold him down. And I won't go through the whole trauma of the event. I cried every time I came up to it. And I didn't realize that that was so deeply etched
sure,
into my soul that I felt like I failed my kid because of what the medical team was telling me to do to him, because they didn't want the responsibility of holding him down and hurting him. So they gave that to me. So that took me a little bit longer than any of my own stuff that I dealt with. It now I'm at the point where I understand that my doctors were ignorant, and I'm a language person. That's not an insult. Like, I'm ignorant about
sure,
so many things, but they were ignorant about what could help me or what I was dealing with. A lot of people don't understand, they don't know, and they're ignorant about the world of connective tissue. And I've become okay with that, but like, that's not fair to preach to, because I literally research this all day, every day. So I have such a deep understanding.
sure.
But even so, like, I still have moments like in the fall when I was, gaslit for bringing up when our kid broke his bone, that I thought that he should be monitored more closely because we had a bone healing problem in the family. And basically had two doctors literally roll their eyes at me and then orthopedist explained to me, like, I don't know orthopedics, how bone heals from an avulsion fracture. And I'm like, cool. Mine don't. You also have screws in your fifth met. Like, nobody has successfully healed the bone this kid just broke. Just, I was on a bone stimulator anytime, every time that I broke a bone.
Not to mention the fact that you just got an X-ray back.
Oh, I wish I had that. It took me
Like,
2.5 years to finally get an X-ray on my injury, and once again, I did not heal bone. Like,
who's
really not
cruising around
well.
with a non-union?
The non-union fracture that I now have. I wish I had that picture so I could have showed them.
Suck on this.
Right. But yeah. So it's complicated, but I'm at the level right now that most of my interactions, I actually do tell my primary care now too, because I go in and I'm always up a little bit and I'm always ready for a fight. And I've been telling him recently, like, sorry, I'm just always expecting people to say no, or I can't help you, or that's weird. That's my favorite one. Like, I'm
And that's
making
like a
something up.
period at the
It's
end of the
like
sentence too. Like that's a conversation stopper.
there's a whole paragraph when people say that's weird. Like, there's so much behind that. Like, that's weird. You can't possibly have that. That's never been reported in science because I've
Literally
never read it
nobody
before.
on the planet doesn't feel bone.
I don't. Yeah. So it is really tough, and that's why I think the other part of it, having somebody in there with you, because the interactions are extremely different. Just having another body. Have I heard from people that it's different when the other body is male? Sometimes, but sometimes just having another body, I hate to say it makes the provider sometimes behave a little bit more kindly because somebody else is in there also watching them. Um, but historically, that is helpful for people.
Sure, probably some unspoken support too, or just acknowledgement of how hard it's been, even if it's acknowledged in the appointment, but perhaps and quite often minimized.
Yeah, and the people that know, like, I'm a shutdown person, having that person there to say, "Mm-mm, don't do this. You said that you were gonna talk about the numbness in your foot. We are talking about the numbness in your foot." So I think it's really helpful to have somebody there, and it's always easier to stick up for other people than ourselves, right? So, like, usually there's a wide variety of people that will go and support you if possible, and I know not in every case, um, but it can be helpful. Yeah, they were always much nicer to me, and they didn't look at me like I was crazy. Oh, one of the things that there was a research article, I forget, it was actually kind of summarized in a news article. I don't remember where it was, but just looking at women and how they were analyzed as being extremely difficult during medical appointments. But when they actually went back and reviewed the medical appointments, the women were just asking questions about their medical care, and that was interpreted as being difficult.
I mean, I don't know when that's from or when the data is from. It'd be really, really curious to look at now too with the AI imprint
Mhm.
of how things are summarized. And, I would hope that it wouldn't apply hysteria to questioning. And I also wouldn't be far removed to know that that's
Right.
happening.
Well, updating my POTS research from the past year, there was an article out. We can link this one in there. I thought it was really good about the gender differences with POTS. And one of the things they talked about was the fact that now men are diagnosed with anxiety. However, women were much more likely to be diagnosed with anxiety than men and wait much longer for their diagnosis than men, and also be at 2.5 times higher risk of being diagnosed with a mental health disorder rather than POTS.
Mm.
So, and that's what they actually, in this study, it was great because they actually looked at it and they're like, okay, but is this a bias on what the patients are providing as
Mhm.
information or on the doctor's side?
Or like
They ran that and they found it's on the doctor's side. The bias is on the doctor's side in interpreting what the patient is telling them from the female patient.
I'm also thinking like limitations, knowing that biologically male humans will also generally wait longer to go in for something.
No, they were
And
diagnosed earlier.
oh wow, okay.
But this is still they're waiting
Sure.
years for a
Sure.
diagnosis. But still, they're diagnosed much earlier. Yeah. And men were more likely to have POTS symptoms after concussion and COVID. But yeah. Okay. Other tips for navigating appointments. I think another thing that I always tell people, the big ones. So the big ones I say are language. Can we work on our language to not seem like we're asking for a diagnosis, but looking for clarity on, imaging and things like that? Supporting yourself, so writing things down or having somebody in with you that can support you can be really helpful.
Knowing if we're just kind of summarizing here, knowing your tendencies and how you tend to react to situations, being able to predict and plan for, again, kind of back to the teaching world. I never understood why we would do this until we did it. And I was like, okay, I can kind of see the application. We used to plan for misconceptions before they even happened.
Mhm.
Like what can you see going wrong with this lesson.
Sure.
And okay, when that happens, how are you going to re-steer the ship, help these students out? Same deal, like appointment wise, like what could go wrong? What's the worst thing that could happen? Like which way could this go? In a little bit, not to the point of neuroses, but working out some of these if thens.
Yeah, and a couple other tips that, like, with that, if it starts to go wrong, now not every provider might take this the right way, but I think it might be helpful for some to offer them an out. So if it seems like this person in front of me is about to really not help me, just asking, "Hey, do you have anybody to refer me to that might be able to help me with the questions that I have?" I'd really appreciate it. So again, switching the
Like
language
an eject
a little
button.
bit, an eject button, but like asking for, like, who would you recommend that might be able to help me with this? Do you have any recommendations? It gives them an out to hand care off to somebody else, and they actually might have a suggestion for you that they weren't about to mention anyway. Crazy. But it might be helpful. So that's another recommendation. I usually tell my patients, throw me under the bus, especially if we're talking about this. We've talked about this in the appointment. You can always say, "Hey, my specialist thought that I might have this." And even from the
I know,
lowly
crazy, right?
providers,
Like she's probably doesn't know what she's talking about,
right?
but
The lowly providers of like physical therapists and occupational therapists, if they document it in their notes that they believe the patient has symptoms that match whatever it may be, if it is documented in the note and it says that we recommend that that individual has further workup with a specialist done, it now can become a liability if that's not looked into appropriately, right? So that's where I usually document it in my notes, like, "Hey, we really think that this patient has intracranial pressure problems. This patient needs, whatever images that we want to do, brain MRI with, without contrast, whatever it might be." But if we can't order that in our state, we can. We are spoiled here in Colorado. But if we have to get that from another provider, or say I have a patient that I want to get checked for a pulmonary embolism, like sometimes you have to write it in the note, and I have the patient pull it up in the emergency room, and they're like, "My PT just, again, here's the language, wants to rule this out." And that's where, like,
may
it's
be
the
completely
craziest
off
thing.
base here, guys, but hear me out.
Just wants to rule it out. They sent this note, and that's where, again, if it's documented in medical care across the board from any provider, it starts to put a liability on other providers, and they might be more likely to listen to it or to refer you out to somebody, or fine, I'll just do the imaging or whatever it might be. But if it's documented by any provider, that can really be helpful. So our physical therapists are, anybody who's in the allied health professions, even nutritionists, mental health professionals, document it in your notes that, like, "Hey, I think it would just be a good idea if this patient were screened for this condition. They have a lot of overlapping symptoms. I hope that their medical provider is able to continue this conversation with them." And you just have them. I always try to tell patients, I just want you to hand my note over. I don't want you to have to try to explain anything. Basically, I'm going to ask for something. Just hand it to them. So that's the other thing too. I tell people, throw me under the bus. Always say, "Hey, my provider or my specialist provider wanted me to ask you about this." So we can use our relationship with others. I take no offense to it, especially if I'm the one saying, "Go ask your provider this." So that's something you can try as well, working with your other providers that might be able to help you.
Yeah, in the same light, I'd challenge other providers out there to keep learning and be the person that I keep thinking back to this fascial counterstrain class that really kind of changed the way I look at some things. This is back in November, and he was really my instructor, incredibly like smart, talented, kind of like a walking encyclopedia type deal. And he was like, "You should be smarter than you are right now for your patients. Like you should be learning more for your patients. Like you're in this field, you want to help, you're in it for the right reasons, and you have an obligation to keep learning
Hmm.
and to press forward and go deeper."
Yeah.
And I mean, I told you about a conversation I had earlier this week where I ended up speaking to somebody that was referred out from a mental health practitioner that's not even, is working on some big, broad topics, but came across, I think, something that you had put out and kind of started to connect some dots and was like, I think you should look into some of the dysregulation that it seems like you're having for your system. It might be anywhere under this umbrella. That's a mental health practitioner, like pushing this patient towards what I felt like was a pretty productive 15-minute conversation that opened some doors. And,
Yeah.
So even cross-disciplinary, being able to hold your weight, in a room.
Yeah. Yeah. I think, and this is something we ran across this week too, is a good provider should never get frustrated with questions. It doesn't make sense why they would, right? I believe that the empowerment is in the patient understanding what is happening in their condition, which is what we're going to talk about in the next podcast, the identifying with the condition. But there shouldn't be offense taken to questions. And I've had 2 people this week apologize for all of the questions. And I'm like, oh my gosh, I love questions. I love questions. It makes me a better provider. It makes me think. It makes me think about multiple different scenarios. And you give me feedback about your personal experience by asking your personal question, but I can assimilate that with everything else that I've heard from people. I love questions. That makes me a better provider in answering questions. So, from a patient side of things,
kind of like a little bit of a red flag.
It's a red flag if they start getting frustrated answering questions. Why? You're just asking to be educated. You should be educated on your own health. Shouldn't you know about your condition that you're dealing with? My goal for my patients is for them to know more about their condition than I even do, because their personal experience is going to be a little bit different.
Informs their knowledge base, sir.
Absolutely. So I know that's kind of we kind of talked about a lot of different things in there. But yeah, there's a lot of different ways. I think planning, like you have kind of come back to a few times, is the planning piece of what do I need to get out of this appointment? How can I get it out of this appointment? And really focusing on that. And again, there's different strategies to get that done. It might look different each appointment, might look different for each person.
All right, great. Well, we'll come back next time and talk about, we're kind of saying identification.
Identifying, yeah.
Cool.
Yeah.
Well, Dr. Patty, thank you so much for your time. Thanks for tuning in. We'll be back with episode 9 in a couple weeks.